Welcome to AETCM, the Emergency Medicine channel. This is Dr. Sabah Ali. I'm a resident here at Amrita Institute of Medical Sciences, and today we'll be discussing about traumatic brain injury, which is yet another video from our EM Rapid series. So what do we know about traumatic brain injury? So it's basically the impairment of the function of brain due to an injury that is caused from an external force. Now, the clinical symptoms can vary from just a mild confusion or a concussion to coma and death, and it can also lead to long-term and short-term sequelae, including severe disability and neurological impairment. Now, apart from this, what we need to know about traumatic brain injury is that studies have shown that the prevalence of traumatic brain injury is twice as high in males than it is in females, and the pattern is a trimodal pattern, that is young kids from 0 to 4 years and adolescents to young adults, like from aging between 15 to 24 years, and elderly people, that is more than 75 years, are more prone to traumatic brain injury. Elderly people, they have neurological impairment, and they are very easily susceptible to falls. They're very vulnerable in that sense, which is why you also see it in elderly people. Whereas in young adults and adolescents, what we majorly see is traumatic brain injury secondary to road traffic accidents. So, how do we classify traumatic brain injury? It can be classified according to the Glasgow Coma Scale, that is GCS, as I think we all are aware of the GCS scoring system. So, let's classify traumatic brain injury into mild, moderate, and severe. Mild is wherein the GCS falls between 14 to 50, and this is majorly what you see is a concussion. 80% is of the concussions fall under mild GCS, but just because a patient has presented to the ER with mild GCS impairment doesn't mean that the patient cannot end up with short-term or long-term sequelae of traumatic brain injury. Now, that's the side effect of GCS, because it can be or it is a drawback of GCS because it can be altered if the patient is intoxicated, and just because the patient's GCS seems to be or relatively better doesn't mean that there has been no significant brain injury also. But for the ease or convenience of our management, we classify it as mild, moderate, and severe. And under the moderate category, GCS falls between 9 to 13, and severe GCS are those with the lowest GCS of 3, and the upper limit or the cutoff would be the 8 GCS. And generally, for severe or traumatic brain injury, we intubate the patient at the time of arrival itself. GCS less than 8, 8 and less than 8 is an indication for intubation. So in this is a pretty significant mortality of about 40%, with most of the deaths occurring within the first 48 hours itself post injury. And fewer than 10% of the patients who have suffered from severe traumatic brain injury experience good recovery. So severe traumatic brain injury results in very poor prognosis. Now let's understand the pathophysiology of traumatic brain injury. Normally there is something called as an autoregulation. So the body itself autoregulates the cerebral blood flow, and that keeps up the balance between the oxygen delivery and the metabolism of the brain cells. Now the upper limit, or rather the lower limit at which this autoregulation becomes dysfunctional, is cerebral perfusion pressure of 60 mmHg. Now, whenever there is high blood pressure or PCO2 washout, or if there is alkalosis as a metabolic disorder, these will affect the cerebral blood flow. How? Because it causes vasoconstriction. Now, because of brain injury, the autoregulation gets impaired, and even a minimal drop in blood pressure will decrease profoundly the brain perfusion, and also it results in cellular hypoxia. So hypotension is extremely, or rather it has a very detrimental effect on the patient's prognosis, because even minimal drop in blood pressure causes profound cellular hypoxia. So cerebral perfusion pressure of less than 60 mmHg, as we discussed earlier, it is the lower limit of autoregulation, and below this perfusion pressure, autoregulation gets impaired and it leads to even more significant brain injury secondary to cellular hypoxia. So we have to avoid hypertension, hypoxia, hypocarbia, and alkalosis in a patient if we were to ensure better prognosis. Now, what's a traumatic hypotension? Basically, in first of all, because of injury, the injured brain has low blood pressure, or the flow itself is low. Now, because of this, the auto-regulation, and even if that also gets impaired, then little of traumatic hypotension, like basically if the patient has any distracting injuries and he's losing blood from some other parts of the body, and there is hypotension, now that itself will cause profound cellular hypoxia, as we saw earlier, and this will also result in even lesser blood flow towards the already ischemic area, because that has been caused secondary to brain injury. So at this point in time, what we have to do is, when a patient has any obvious injury which can lead to blood loss leading to hypovolemic shock, we need to treat the patient with aggressive fluid resuscitation, because our primary agenda is to prevent hypotension. Because I cannot stress this enough that again hypotension causes cellular hypoxia, and the injured parts of the brain will have even more profound detrimental effect if there is hypovolemia and hypotension in a patient. Now, in that sense, we will have to prevent hypotension at any cost to maintain a mean arterial blood pressure of more than 80 mmHg. Now, normally for trauma patients, which does not involve traumatic brain injury, we prefer to keep, like in cases of sepsis or trauma, we prefer to keep a MAP of more than 65 mmHg. But in TBI, this MAP becomes more than 80 mmHg. So that's the difference between traumatic brain injury and injury due to any other cause like sepsis or hypovolemia due to any other cause. Now, what happens is, when there is low blood pressure, there will be elevated intracranial pressure as a compensatory mechanism, and this will result in low cerebral perfusion pressure, which will again further cause brain injury. That is a secondary brain injury. Now, the other entity that we need to know about is the Cushing's reflex. Now, Cushing's reflex is seen in traumatic brain injury, which is nothing but a triad of three things. Cushing's reflex is a triad of three things: irregular breathing pattern, that is, irregular respiration. Then there is hypotension. Hypertension. And then there is signs of increased ICP. So this is the Cushing's reflex, and this signifies that the patient has ICP, traumatic brain injury, raised ICP. Now, this is what we need to look for in a patient with traumatic brain injury. Now, moving on to something called as Monroe-Kelly Doctrine. Now, Monroe-Kelly Doctrine says that the ICP is determined by, you can determine the ICP with three intracranial compartments. Now, that one is brain parenchyma, which occupies about 80% of the brain volume, then CSF and intravascular blood volume. So that is about 10%. Brain parenchyma, 80% of the intracranial compartment, 10% each will be CSF and intravascular blood. Now, when one compartment expands, then there will be so basically it is divided as that. This will be the brain parenchyma. The 10% each will be the CSF and blood. So when one compartment increases, when either one of the compartment increases, then there will be compensatory reduction in the other part of the uh, intracranial compartments. So this will be to maintain the ICP. So what happens is whenever there is blood secondary to traumatic brain injury, and this compartment from 10% increases to, let's just say, about 40%, then in that case what happens is there will be compensatory reduction in the other two intracranial compartments. So in this case it will lead to increased ICP because the pressure has been increased, and this can have compressive effect on the brain parenchyma. Why? Because the sum of these three compartments, intracranial compartments, has to be a constant. This is the Monroe-Kelly doctrine. So what the doctrine states is that the ICP is determined by the volume of three compartments of the brain, that is the parenchyma, the cerebrospinal fluid, and the blood. So 80%, 10%, 10%. Now this sum always has to be constant. So any increase or expansion of either one of the compartments will lead to compensatory reduction in the other two compartments. This is Monroe-Kelly doctrine. So moving on, how do we classify injuries? It can be a primary injury and a secondary injury. Primary injuries are those that is caused by direct impact on the brain parenchyma. Now it can lead to contusions, hematomas, diffuse axonal injury, that is the DAI, and it can cause cellular damage and even loss of the blood-brain barrier. Now what are secondary injuries? Sometimes secondary injuries, they will be used synonymous to the injuries that is caused secondary to either traumatic hypoxia or hypocarbia, alkalosis, hypertension, but no, secondary injuries do not include all of that. Secondary injuries is the neurotoxic cascade. What happens is whenever there is brain injury, there will be a massive release of neurotransmitters. The inhibitory neurotransmitter like glutamate will be released into the presynaptic space, and along with this there will be activation of NMDA receptors, along with the other receptors. Now because of all of this massive release of neurotransmitters, inhibitory transmitters into the presynaptic space, it will lead to mitochondrial cell damage because of the ionic shift. Now this will result in cell death and necrosis. Now this constitutes to secondary injury. Now there are way too many pro-inflammatory markers that get released, and the cytokines that get released. These are released in order to clean and also repair the damage, but they can also cause further injury. Now this, along with this, there will be also release of free radical ions, and all of these further cause cell death and necrosis, and those produce extensive neuronal loss. Now this is what is responsible for the brain injury sequelae. Your short-term and long-term sequelae. Those cells that have survived, they will undergo apoptosis and programmed cell death. Now let's learn something about brain herniation. Now majorly there are four brain herniations. One is the uncle herniation, which is the most common. After this there is central transtentorial herniation, then there is cerebello tonsillar, and then there is upward posterior fossa herniation. What happens is because of increased traumatic brain injury, there will be increased blood and edema. All of this will cause expansion of the brain volume. But as we know, cranium is a closed cavity. So because of this, there will be increased intracranial pressure, now which further compresses on the brain parenchyma. And wherever there is, and we all know that brain parenchyma floats in the cerebrospinal fluid. We have the foramen of Monroe and we have all these openings. Now, because of increased cranial intracranial pressure and because of constant compression over the brain parenchyma, this brain parenchyma, it herniates down either towards the foramen of Monroe or these openings, which will cause compression of the major intracranial nerves, which will be which will again have a detrimental effect. Now, what is uncle transtentorial herniation? This is the most common herniation. Here, what happens is the uncus gets compressed in the brainstem area. So this will cause the compression of the parasympathetic fibers of the third cranial nerve, which is the oculomotor nerve. And because of this, the ipsilateral eye will become fixed and dilated because of unopposed sympathetic tone. And if the pyramidal tract is also compressed, it leads to collateral uh, motor paralysis because of the crossover. So, what we need to know is if you see ipsilateral fixed and dilated pupil, we can, there's a good chance that the patient has landed up with uncal herniation. What is then after this, the all the other tensiontorial will have pinpoint pupils. How do we differentiate if the patient has pinpoint pupils? If the patient has increased muscle tone with Babinski sign being positive bilaterally, it is because of central transtentorial. And it is also caused by, you'll have mixed fixed midpoint pupils and patient ends up with prolonged hyperventilation and decorticate posturing. Cerebellotonsillar, there will be pinpoint pupils, but the patient won't have increased muscle tone. Instead, it's quite the opposite. Patient ends up with flaccid paralysis and can also lead to sudden death. Now, what happens in posterior fossa? As we all know, there is 17, area number 17 in the posterior part of the posterior fossa that is connected to the eyes of thalamic center. So, because of that, patient, whenever there is herniation, it causes conjugate downward gaze with absence of vertical eye movements. So the patient won't have any vertical eye movements and there will be conjugate downward gaze and with pinpoint pupils. This is how we figure out the major brain herniation syndromes just by physical examination or only by pupil examination. Now, clinical features, like we discussed earlier, it has a range of symptoms. There's a constellation of symptoms. It can either range from a minimal confusion or a concussion to major severe disability, coma, and death. So, how do we figure out or detect the clinical features? Is that we take an accurate history. Most of the time, patients who come to the ER with history of traumatic brain injury might not be in their full GCS. They'll either be confused or they'll be only responding to pain. And in some cases, the GCS can be extremely low. And most often, there wouldn't be even witnesses around. It can be a hit and run case, or patient could have just fallen off a building and nobody would have noticed. They could have just found him lying on the by the side of the road covered in blood. All of these are the possibilities. So unlikely or if the elderly patient is left unattended at home and he's had a slip and a fall, any of those cases, it is difficult to obtain accurate history, but we need to obtain as much of history as we can from the patient, people who have witnessed the event, and also the EMS crews. Those are the paramedics who would have gone to the site of injury and then gathered information from them. So once the patient is brought in an ambulance to the ER, taking adequate information from the paramedics is crucial. So, along with this, what is the other data that we need to know is the patient's past history. Is the patient on any antiplatelets, any anticoagulants, or is the patient under the influence of alcohol or any usage of any illicit drug? Because if the patient is intoxicated with alcohol or drugs, then the GCS can be low. And then in that case, it becomes very difficult for us to figure out whether the low GCS is secondary to alcohol intoxication, like whether he has passed out because of alcohol, or is his GCS is low because of the traumatic brain injury. So obtaining adequate history and also past history of traumatic brain injury is extremely crucial. Now, in our initial clinical findings and physical exam, we also can gather information as to how badly the patient has been injured, and this I cannot stress enough that it has to be obtained from a paramedic, because that becomes constitutes an essential component in triaging and managing traumatic brain injury. So, in physical examination, how do we go about once we have gathered information? We go, physical examination, we approach the cases trauma focused. Now, this is the key word. Physical examination has to be trauma focused with simultaneous life saving procedure to be done as needed. For example, when the patient comes to the ER with a history of traumatic brain injury, then the physical examination and the intervention, life saving interventions, have to be done parallelly. Like, we need to provide a manual inline stabilization to stabilize the cervical spine. We have to put the cervical collar. At the same time, we have to manage the airways. We have to anticipate difficult airway, keep the difficult airway trolley ready. Then, if the patient is conscious or unconscious, depending on that, we have to rule out whether the patient has any basal skull fracture signs, so that we have a better insight into how we are going to approach this case. Then we'll have to see the patient's breathing, manage, have interventions accordingly and simultaneously with providing supplemental oxygen, or whether the patient will require intubation. Then a quick screening has to be done, circulation, check the hemodynamic status, and most importantly, we'll have to check the pupils, whether the patient has bilaterally symmetrical and reactive pupils, or whether the patient has ended up with anisocoria, fixed dilated pupils. All of these have to be checked, and apart from that, patient has to be exposed completely to see if there's any other obvious injuries, any distracting injuries, and also cover the patient back up so as to prevent hypothermia. So physical examination has to be trauma focused, it has to be parallelly done, and it has to go in this order: airway, breathing, circulation, disability, and exposure. And interventions have to be done parallelly. It's not like we it's not like we check airway, breathing, circulation, and then do interventions for airway. We see that there is a problem with airway, we handle the airway problem, simultaneously go to breathing. If the patient has low saturation, we put the patient on supplemental oxygen. At the same time, we check the patient's hemodynamic status, and then we insert two large IV bore cannulas, start aggressive fluid resuscitation if the patient has hypotension. Then we move on to disability. So it has to be done simultaneously and parallelly. And then we check for the signs of elevated ICP. Now, what are the signs of elevated ICP? Now, what are the signs of elevated ICP? Patient can end up with projectile vomiting, What is a projectile vomiting? Wherein the patient does not have any nausea and patient just throws up. There will be projectile forceful throwing up of gastric contents without the preceding nausea. So patient just throws up like that. So that is projectile vomiting. Patient can have anisocoria. Anisocoria again can mean herniation. Patient can have confusion, that is altered mentation. Patient can end up with hypertension, bradycardia. Basically, Cushing's. Oh, I think in my some time ago I said hypertension, bradycardia, and irregular respiration. This is Cushing's reflex. I think some time ago I said instead of bradycardia, increased signs of ICP. Basically, Cushing's reflex is increased ICP feature, and it comprises of hypertension, bradycardia, and irregular respiration. I want you to I want you all to know that Cushing's reflex is a sign of raised ICP, and it constitutes of three things: hypertension, bradycardia, and irregular respiratory pattern. Apart from this, we need to protect the cervical spine by providing manual inline stabilization and then applying cervical collar cautiously. And if the patient requires intubation, then intubation has to be intubated while providing the manual inline stabilization. Now, if emergency intubation is required, then pre-intubation GCS has to be checked, and also patient's hemodynamic status also has to be recorded. So GCS and pupillary response pre-intubation, we need to make a record of it, because post-intubation, if at all patient has had further deterioration, then we can figure it out by GCS and pupillary response. So pre-intubation GCS and the patient's best score has to be recorded, because GCS has more scope in in a prognostic, as a prognostic marker, and pupillary response. So let's learn about the different kinds of traumatic brain injury. This is epidural hematoma. As we know, epidural hematoma is an arterial bleed. It's an arterial bleed. So it will be concave shaped. It will be a convex shaped arterial bleed, and it is because of middle meningeal artery rupture. Generally, when there is a traumatic brain injury which affects the temporal area, the middle meningeal artery gets injured, and from there, since it's an arterial blood can squirt out into the space, and which is why this becomes an emergency and will require bedside EVD as a life-saving procedure. So that's about epidural hematoma. And apart from that, patient can also end up with something called as lucid interval, meaning soon after the injury, patient can lose consciousness, but he will wake up and he will be pretty normal. In fact, his GCS can even be 15 on 15. So that is his lucid interval. And you might think, because the patient's GCS is normal, then there is probably no much of injury. but then suddenly patient can deteriorate and slip into coma and can even be dead. Now that's because of lucid interval, wherein the patient appears to be normal, a period of awakening in case of traumatic brain injury, wherein the patient has achieved full GCS and then the patient will suddenly deteriorate. All of these are characteristic of epidural hematoma. Now then there is something called as contusion or hematomas. As we see, these are all the cerebral edema areas, the contused areas. This is the intraparenchymal hematoma. Diffuse axonal injury, it's not very evident on CT brain because it is and it is checked in, it has a better visualization on MRI because it's at the differentiation of gray white matter. It is basically the axons that get injured, and on CT, except for minimal cerebral edema and petechial hemorrhages, there's nothing much that will be picked up on CT. But on an MRI, diffusion axonal injury can be assessed. Now, how do we, or rather, when do we suspect diffuse axonal injury? When the injury is minimal, signs are minimal, but the patient looks sick. Basically, patient has worse clinical features, but without much of evidence backing it up. Like for example, patient has a very low GCS and we send the patient for a CT scan. And CT scan, there are no much findings except for probably diffuse cerebral edema, but nothing very profound. But patient has an extremely low GCS when is not even responding to pain. Now, in that case, we suspect diffuse axonal injury, or the patient has severe neurological disability, but imaging doesn't show as much of damage or injury. In that case, we suspect diffuse axonal injury. And then there is subdural hematoma. Now, subdural hematoma is a venous bleed. It's a venous bleed wherein the communicating bridging veins, where the communicating bridging veins get torn. Now, in that case, the blood will trickle because there is no much of force. So, it will be a concave or a moon shaped or a crescent shaped bleed. See, as we see here, this is concave, convex. This is because of the middle meningeal tear. Now, this blood has trickled. This becomes subdural hematoma. Subdural hematoma again can be acute, subacute, and it can be chronic. Subarachnoid hemorrhage is basically hemorrhage in the subarachnoid space, wherein you can see these. These are subarachnoid hemorrhage. And this is generally or majorly we see it in any aneurysmal rupture, but traumatic brain injury can also cause bleed into the subarachnoid space. And this is just diffuse swelling, cerebral edema. Yeah. So now let's move on to two criteria: the nexus criteria and the Canadian Cspine criteria. Now these are the criteria to figure out whether we need cervical spine imaging or not. These are the criteria to assess whether cervical spine imaging is needed or not. So we look into the 5 parameters: whether the patient has any focal neurological deficit, whether there is any midline cervical spine tenderness, whether the patient has any altered mentation, Is the patient under the influence of alcohol or drugs, basically intoxicated, or does the patient have any distracting injury like a gaping wound on the thigh or a broken open fracture on the limbs? Any of these distracting injuries, if any of the criteria is positive, then this indicates that we have to do cervical spine imaging. Similarly, there is another criteria called as the Canadian Cspine rule. Now, in this, we go in gradations to find out whether the patient will require cervical spine imaging or not. Like, we check if there are any high risk factors, like is the patient an elderly patient of more than 65-year age, if the patient has sustained injury through a dangerous mechanism. Dangerous mechanism meaning patient has to have a 5 flight of stairs fall, or patient should have a 3-meter height fall, or it has to be a heavy motor vehicle collision, like a lorry with a cycle, lorry with a pedestrian, lorry with or a car with cyclists. Basically, heavy motor vehicle injuries, 3-meter height fall, or a height of 5 flight of stairs. All of that accounts to dangerous mechanism, or if the patient has any focal neurological deficits, any paresthesias, then that's a straightaway indication for imaging. Now, if the patient does not have any, then we come to the second tier. In the second tier, we see if the patient has any low risk factor. Excuse me. That is whether it's a simple rarent motor vehicle collision, or if the patient is sitting down in the ED, has been ambulatory at any point in time, or if the patient has a delayed onset of pain, not immediate, or if there is any absence of C-spine tenderness. Now, all of these are low risks. If not even one of the low risks are present, then we go for radiography. But if low risk factors are present, then in that case, we will go to examine the patient's range of movements of the cervical spine, wherein we ask the patient to rotate his neck 45 degrees on either side. And still, if the patient is able to actively do it without any discomfort or pain, then patient won't require any radiography. But if the patient, while rotating his neck on either side 45 degrees, complains of pain or discomfort, we go straight away with cervical spine imaging. So these are the two famous criteria that can be used when you're in doubt whether we have to take the patient for a cervical spine imaging or not. Similarly, for to take a CT scan of the head, there is again something called as New Orleans criteria and the Canadian CT spine rule. So this is the New Orleans criteria. This is the Canadian CT spine rule, CT head rule, sorry. So in that we see, but these are applicable only if the patient's GCS is 15. Canadian CT rule can be applied when the GCS is between 13 to 15. If anything less than that, then we have to go for a CT imaging. Now, if the patient has a full GCS of 15, then we look for any signs of increased ICP, headache, vomiting, or if the patient has had seizures, bradycardia, or if the patient's age is more than 60 years, or if he's intoxicated, patient suffering from amnesia, or there is any evidence of trauma above the level of the clavicle, then seizures, all of these will account. There's again an indication of for the patient to be taken for a CT scan. Now, when we take a look at CT head rule, Canadian CT head rule, in this the patient has to have a GCS of at least 13 and above. But if there is any drop in GCS less than 15 for about or in about a span of 2 hours, it's an indication to take the patient for an imaging. Or if the patient has any depressed or open skull fracture, elderly patient with age more than 65 years, patient has more than one episode of vomiting, or if the patient has continued retrograde amnesia for more than 30 minutes. Please note that here for New Orleans, age is more than 60. For Canadian CT spine, CT head rule, it is more than 65. Here it is anterograde amnesia, whereas here it is retrograde amnesia. And then there is dangerous fall. That is fall for more than about 3 feet, or if he is for a heavy motor vehicle, especially when he is a pedestrian. And then there is any sign of basal skull fracture. What are the signs of basal skull fracture? Your raccoon eyes, battle sign. Battle sign is basically wherein you have a hematoma or a discoloration behind the ear in the mastoid region. That is called as a battle sign. Raccoon eyes, because of the trickling of the blood in the congenital spaces, you'll have raccoon eyes. Then hemotympanum. All of these are signs of basal skull fracture. Then is identification of patients who have an intracranial lesion on CT. So this is 100% sensitive and this is 83% sensitive. So a negative feature of these two decisions is that loss of consciousness or amnesia is required at the time of as an entry point. Yeah, this is less than 15 amnesia. Yeah. This is a CT scan for adults with brain injury. So this is according to the American College of Emergency Physician. These are the guidelines that adults with GCS of less than 15 at the time of evaluation should undergo CT scan, that is mild traumatic brain injury with or without loss of consciousness. So this has an upper hand because in these two, in order to take these criteria into consideration, patient should either have an amnesia or patient should have loss of consciousness. Whereas for this criteria, the patient can just have mild traumatic brain injury with or without loss of consciousness if one or more of the following is present. That is, GC has to be less than 15, any focal deficits, vomiting more than once, that is, but not twice, more than 2 times, moderate to severe headache, age more than 65, physical signs of basilar skull fracture, patient has coagulopathy, or if the mechanism of injury was dangerous. Now, mild traumatic brain injury with loss of consciousness or amnesia. If patient has any persistent amnesia, seizures, evidence of injury above the clavicles, and intoxication. Basically, these people have adopted a criteria by combining these two criteria. So moving on to the last segment, that is the treatment. So we have to set primary goals of treatment. So in order to maintain cerebral perfusion and oxygenation, we have to optimize intravascular volume and ventilation. What all do we need to avoid? What we need to avoid is hypertension, hypotension, hypocarbia, hypoxia, hypoglycemia, so these are the things that we need to avoid. So this will prevent a secondary injury, secondary to hypoxia, hypocarbia, then hyperglycemia, hypoglycemia, hyperthermia, hypothermia, and hypoperfusion. Then we need to recognize and treat if there is any elevated signs of ICP, that is Cushing's reflex, bradycardia, irregular respiration, and hypertension. Then, if at all patient has the requirement for neurosurgical intervention, it has to be done at the earliest to evacuate any mass lesions. Like if the patient has massive blood loss, or it's a epidural hematoma which requires bedside EVD, or because of that there is compression of brain parenchyma, herniation. This all of these calls for urgent neurosurgical intervention for decompressive craniotomy, craniectomy. So patient has to, so we all have to involve the neurosurgical team at the earliest and mobilize the patient for immediate neurosurgical intervention. And we also treat any other life-threatening injuries. So what are this is the checklist for ED treatment for brain injury. In cervical spine, like I said, we need to maintain the manual inline stabilization and provide proper immobilization of the spine. Airway, we need to assess the airway, anticipate difficult airway, be prepared for surgical airway if at all need be. And if the patient has a GCS of 8 or less than 8, we need to intubate the patient, but pre-intubation GCS and pupillary response, patient's best course has to be recorded. Then oxygen and ventilation, we keep an oxygen saturation of more than 90% and a PCO2 of 35 to 55 mmHg. Then BP, we keep a map of 80 mmHg with a systolic blood pressure of more than 90. At any costs, we prevent hypotension. After aggressive fluid resuscitation, also if the patient has had persistent hypotension, if the patient has fallen hemoglobin, then we transfuse blood and blood products. Then, but we also start on early vasopressors, that is to keep the systolic blood pressure of more than 90 and a map of more than 80. No permissive hypotension. Permissive hypotension, this concept does not hold good for traumatic brain injury because, like I said, the ischemic area will further worsen because the injured brain areas will also already have low blood flow, cerebral blood flow. Then when we talk about physical examination and GCS, we have to assess the patient's GCS because during intubation, we induce anesthesia and we paralyze the patient. So in that point in time, we won't be able to properly assess the initial GCS, which is why we have to make a record of all of this before we give paralytics to the patient. And simultaneously, if there are any life-threatening injuries, that has to be taken into account, noted and treated accordingly. And has, like I said, this has more of prognostic feature. Then we send the patient for we have to secure the airway and then shift the patient for CT scan to see if there is any cause for the increased ICP, any herniation, to assess the severity of the bleed and all of that. And if need be, cervical spine CT also has to be taken depending upon the criteria, the Nexus and Canadian C-spine criteria. Then once the patient is brought back from CT, we have to again check the patient's pupils and GCS and also keep an eye for signs of increased ICP. Then glucose has to be maintained between 80 to 180 mmHg in order to prevent hyperglycemia and hypoglycemia. And then we have to prevent hypothermia and hypothermia and maintain the body temperature between 36 degree Fahrenheit to 38.3 degree Fahrenheit. Then to an extent, therapeutic hypothermia has been suggested with aggressive cooling. Seizure prophylaxis, previously there was, now what we say is for seizure prophylaxis, there's no indication to give anti-seizure medication unless the patient has one episode of seizure. But if the patient has severe traumatic brain injury, then it is advisable to give an anti-epileptic in order to prevent seizures. So not all traumatic brain injury warrants anti-epileptic drugs. So we identify and treat ICP or herniation. There are certain things that we need to do bedside itself that can help in reducing the ICP. One is 30-degree elevation of the head end we avoid any necklines, we adequately sedate the patient and provide ample analgesia, because any agitation from the patient, uh, and if patient has pain, or a patient is aggressive, this can further increase ICP. So we keep the patient as calm as possible by providing adequate analgesia and sedatives. Along with this, we keep the head end about 30 degrees centigrade. We frequently assess the hemodynamic stability, maybe every 15 hours if it is a severe traumatic brain injury, or every half an hour. And then we avoid hypoventilation and hyperventilation, hypocarbia. And if the patient, if there are any signs of herniation like anisocoria and all, we give mannitol, 1 gram per kg IV bolus. Now bolus is important because generally people just put on the drip and let mannitol flow over a span of 15 to 20 minutes. That shouldn't be done. It should be given bolus push, mannitol 1 gram per kg. And the other thing that we can start is a 3% saline. And then neurosurgical team has to be involved if patient requires any interventions. So this is the main checklist that we have to make sure we take into consideration when a patient comes. Now, what are the important things is nasotracheal intubation has to be avoided if the patient has basilar skull fracture or if there is any facial trauma. It's not just the nasotracheal intubation, even the insertion of nasopharyngeal airway is also contraindicated if there are any signs of patient skull fracture. And then we maintain inline stabilization, like I said, even during intubation. Then we maintain adequate ventilation, oxygen, prevent hypoxia, hypocarbia, and hypercarbia. And then we keep PCO2 between 35 to 45 or 55. Then PaO2 has to be more than 60. Oxygen saturation has to be kept more than 90. SBP more than 90. MAP more than 80. So since permissive hypotension, like I mentioned earlier, it will worsen the outcome. So the induction agents that are used for intubation will be etomidate and propofol. Propofol causes hypotension, so we have to be very careful before giving propofol. It is given as 1 to 3 milligram per kg IV bolus, but hemodynamic status also has to be kept in mind before we give propofol. But what is the added advantage of propofol is that it has an anti-seizure property. Whereas etomidate, if the patient has hypotension, then etomidate becomes a wiser option to take, because it is neuroprotective. It doesn't alter the patient's hemodynamic status, doesn't cause tachycardia or hypotension, and it can, to an extent, lower intracranial pressure also. And paralytic agents, either succinylcholine or rocuronium, can be taken as 1 to 1.5 milligram per kg, rocuronium in a dose of 0.6 to 1 milligram per kg. So all of these are short acting, and these are the drug medications that can be taken for during intubation. And for pre-medication, fentanyl can be used. For pre-medication. Now, why is fentanyl? And it is given as 1 microgram per kg dose. And fentanyl is used as a pre-medication agent because it has both properties of being anxiolytic and analgesic. So adequate sedation and analgesia, patient positioning to 30-degree head end elevation. Then we achieve adequate glycemic control by keeping it between 100 to 180 milligram per deciliter, prevent hypothermia and hypothermia. And then seizures after head injury can cause oxygen deprivation, hypoxia basically. It can also increase ICP, which is why for severe traumatic brain injury, it is advisable to give anti-epileptic drugs. And then mannitol and hypertonic saline also helps in reducing ICP, but mannitol should only be given if we are suspecting severe traumatic brain injury or there is herniation, only in that case we give mannitol as bolus 1 gram per kg. But mannitol is actually an osmotic diuresis and it causes hypotension. So it is best avoided if the patient has hypotension. But if the patient has uncal herniation, then this can be given. But if the patient has persistent or significant hypotension, then hypertonic saline becomes a better agent to give in order to lower the ICP. Now, these are the goal-directed therapy, wherein, just to sum up, pulse oximeter, basically saturation should be more than 90%, SBP more than 90, MAP of more than 80, PCO2 35 to 45, and temperature has to be kept between 36 degree Fahrenheit to 36 degrees Celsius to 38.3 degrees Celsius. Cerebral perfusion pressure should be more than 60 because below that autoregulation becomes impaired. ICP should be kept less than 20 mmHg. pH should be normal 7.35 to 7.45. Glucose between 80 or 100 to 180. Then sodium has to be kept. It is better to keep it at the upper limit of normal, that is between 140 to 1 between 140 to 145. If the patient has increased ICP, and then INR coagulopathy, INR has to be less than 1.4, platelets more than 75 thousand, and hemoglobin of more than 8 gram per deciliter. So if the GCS is less than 8, we provide intubation and also take the patient for an emergency extra EVD procedure, extraventricular drainage, and this is generally done bedside in order to monitor the ICP, and also it has a therapeutic effect because when CSF gets drained, so ICP comes down, and ICP of more than 20 mmHg increases mortality and morbidity. Early consultation for neurosurgical intervention for direct ICP monitoring for CSF diversion like extraventricular drain. It's highly recommended in cases of moderate and severe traumatic brain injury. So to sum up, we have epidural, subdural, subarachnoid, and intracerebral hematomas. This is generally happens in young people, and it happens in the epidural space, that is between the skull and the dura mater. It is biconvex, football shaped, biconvex basically, and it is an arterial bleed from the middle meningeal artery. Majorly happens in the temporal region, and it causes immediate LOC with a lucid period that occurs in about 20%, wherein the patient has achieved full GCS before he finally crashes. In subdural, this is generally seen in elderly patients because they have very tender communicating bridging veins. So even trivial trauma can cause rupture because of that shearing force. It can delicate veins can rupture, and it is a venous bleed, and it can trickle between dura mater and arachnoid, and it is sickle shaped or moon shaped, crescent shaped, and it is because of acceleration and deacceleration which causes tearing of the bridging veins. In this, if it is an acute SDH, there can be immediate or LOC, or if the patient has chronic SDH, then patient over a span of time can have fallen sensorium. In subarachnoid age, it can happen in any of the age groups, and there will be blood in the cisterns. Again, because of acceleration and deacceleration, the vessels in the subarachnoid space can tear up, and it can cause mild, moderate, and severe injury depending upon the grade of damage. Contusion is basically seen majorly it can occur in any age group, but in babies it is usually secondary to baby shaken syndrome because of assault or batter baby syndrome, and it causes profound cerebral edema. So this is all that we have for today. Traumatic brain injury is basically an impairment of the brain function. It can be divided into mild, moderate, and severe depending upon the GCS. Up till 14 it is mild, 9 to 13 becomes moderate, and GCS of less than 8 to 3 becomes severe traumatic brain injury, which has a mortality of roughly about 40%. And it can be because of primary injury because of the direct impact, or it can be secondary injury because of massive release of neurotransmitters, free radicals, oxygen radicals, then because of release of pro-inflammatory cytokines. And we have to prevent hypotension, hypertension, hypocarbia, hypothermia, and also hyperglycemia. So we have the goal directives with wherein we maintain MAP of more than 80, cerebral perfusion pressure of less than 60, ICP of less than 20, CPP of more than 60, ICP of less than 20, PCO2 of between 35 to 45, maintaining saturation of more than 90% with a PaO2 of more than 60, and then sugars have to be maintained between 80 to 180 mmHg, milligram per deciliter. And so pH has to be normal between 7.35 to 7.45. Types will be epidural, subdural, subparenchymal, and intraparenchymal or intracerebral hematoma. And this is an arterial bleed. This is the venous bleed. So clinical features can range from mild confusion to even severe disability, coma, and death. So with this, I sum up my session for today, traumatic brain injury. Thank you.